Okay, greetings everyone. Welcome to Medicare's Home Healthcare Benefits webinar. This is being hosted by Paralyzed Veterans of America and presented by the Center for Medicare Advocacy. Next slide. I'm Susan Prokop with the PVA Advocacy Program, and I'm just going to run through a few administrative items and introduce our speakers today before turning it over to them. Today's webinar is being recorded and will be available for viewing on the pva.org website. We've got closed captioning available. There should be a little CC button in the meeting controls bar at the bottom of your screen to turn it on if desired. And if you have a question, we ask you to type it into the Q&A box that is available at the bottom of your screen. We'll hold questions till the end of the presentations, but try to get through as many as we can. And on the next slide, we'll begin the introduction. So we are delighted to have with us today Kathleen Holt, Associate Director and Attorney, and Wei Kwok, Senior Attorney for the Center for Medicare Advocacy. And we are grateful to them for making this presentation about Medicare home health care. And I'm going to turn it over to Kathleen and Wei for a description of the center and to take it away on the presentation. So go for it.
Okay, hello, good day everyone. Thank you, Susan. Next slide, please. Okay, so let me tell you a little bit about the Center for Medicare Advocacy first. We are a national law organization founded in 1986 that works to advance health equity and access to comprehensive and quality health care for Medicare beneficiaries. We have headquarters in Connecticut and Washington, D.C., and our staff provides education, legal analysis, and assistance. And our policy and litigation work stems from the real problems we hear about from Medicare beneficiaries. Next slide, please. So I just want to quickly go over the agenda. So I am going to be reviewing home health coverage criteria on pretty basic level. And also, then after that, Kathy is going to talk about obstacles to accessing covered home health care and also go through a case study that's very helpful. And we're actually going to move up the question and answer section to right after the case study, because we do want to address your specific questions. And in doing so, we'll probably touch on some of the practical tips and resources that will be helpful to you. Next slide, please, Rhonda. Oh, I'll go back another one. Thanks. Okay, so we're going to be talking about home health today. The Medicare home health benefit, importantly, allows homebound individuals to obtain medically necessary health services in their place of residence from a participating home health provider. For several years now, the Center for Medicare Advocacy has been really concerned about the increasing reports of people being unable to access the type and amount of home care they need and for which they are eligible. In many instances, these are beneficiaries with chronic, disabling, and sometimes complex medical conditions who are being denied care based on inaccurate or misleading information about Medicare coverage. So today I will go over the services and items that are included in the home health benefit and explain the eligibility requirements for coverage. And the information I'm providing is based on statute, regulations, and Medicare's policy guidance. Next slide, Rhonda. Okay, so this slide shows the 3 general requirements to qualify for home health coverage. First, the person must be under the care of a physician or an allowed practitioner who certifies their eligibility and establishes and orders a plan of care for home health services. Home health is provided in 60-day episodes, so that plan of care must be reviewed by the physician at least every 60 days. Secondly, the person must be confined to the home, and more specifically, they have to meet Medicare's definition of homebound, which I'll discuss in more depth shortly. Home is anywhere the person lives. It could be their own or a relative's dwelling. Home can include an assisted living facility or a group home that is not primarily engaged in providing skilled medical services, so not a skilled nursing facility. The third eligibility requirement is that the person must need a skilled service that is medically reasonable and necessary to treat their illness or injury. And that skilled service must be ordered in the home health plan of care. So these are the three qualifying criteria that trigger coverage under the benefit. Now, there are additional technical requirements that the home health provider must meet in order for them to get paid by Medicare. So in submitting a claim, the home health company must show that the patient has actually been examined by a physician related to the reason why the patient needs skilled home care. And this is what's known as a face-to-face encounter. The provider must also make sure that the physician who orders the services properly certifies and supports with medical documentation why they believe that their patient is homebound and needs skilled care. Next slide, please. So if the individual meets the three criteria I mentioned, though, then they qualify for coverage of home health services. So what are those services? We know that the patient must need a skilled service at home, and that will either be intermittent skilled nursing, physical or speech therapy, or continuing occupational therapy. So if they're receiving at least one of these skilled services, then they're eligible for coverage of dependent services that are needed in relation to their illness or injury. Now, dependent services can include home health aides to provide hands-on personal care, medical social worker services, and medical supplies. Now, the plan of care has to include specific orders for these dependent services. Next slide, please. So there's no time limit or cap on how long someone can be eligible for home health benefits. As long as the person needs a qualifying skilled service and meets the other threshold criteria, then coverage would continue to be available. Medicare does not limit the number of covered visits or continuous 60-day recertifications for beneficiaries who continue to be eligible for the benefit. So if you hear an agency say that it's only a short-term benefit, or that Medicare only covers a certain number of visits or episodes of home health, that is plainly false. Next slide. So let's look at the homebound requirement more closely. To be considered homebound by Medicare, a person must meet a two-prong test. In the first prong, the patient must, because of an illness or injury, need the aid of a supportive device, such as a cane, walker, wheelchair, or special transportation, or the assistance of another person in order to leave their home. Now, understand that we're not just talking about physical limitations. The assistance of another person may be needed because of cognitive or mental limitations. Barring this, though, the person would need to have a condition such that leaving home is medically contraindicated. An example of this is someone who is severely immunocompromised, or whose heart condition is so severe that their doctors told them to avoid all physical activity. Okay, under the second prong, there are two additional criteria. There must exist a normal inability to leave one's home. And well, the agency has never expressly defined what a normal inability means, but the guidance suggests that the requirement would not be met if someone is leaving home on a frequent or regular basis or for long periods of time for non-medical reasons. The second requirement is that leaving home must entail a considerable and taxing effort. Next slide, please. So Medicare has clarified that certain absences from home would not by themselves disqualify someone from being considered homebound. Specifically, you can leave home for the purpose of obtaining health care, and this includes medical appointments or receiving therapy that can't be provided at home, either because it entails special equipment or technology. In attending adult daycare for the purpose of therapeutic, psychosocial, or medical treatment also counts as health care. But it would need to be in a structured setting of a licensed and certified or accredited adult daycare program, as opposed to an informal drop-in program at a senior center. Under Medicare policy, infrequent or short absences from home are also allowed. This includes attending religious services or unique events like a family reunion, funeral, or graduation. Occasional walks around the block or trips to the barber likewise would not disqualify someone. Next slide, please. So it's valuable to take a deeper look at a person's outings because agencies often miss the true nature and difficulty of those outings. For instance, agencies often conclude that someone is not homebound because they regularly visit relatives. But on closer examination, we might find that an adult child is really bringing their parent to stay at their home each weekend to provide necessary care and companionship. Now, the policy says that you can split time between two residences, such as a relative's home or even a vacation home, so long as you meet the homebound criteria in whichever location you're in. Agencies sometimes conclude that a person's not homebound because they operate a power wheelchair or scooter. Now, this sometimes ignores the considerable and taxing effort or assistance it might entail for the person to prepare for an outing, to transfer to and from their wheelchair, and also to navigate outside of the home. So we think that an agency still needs to consider if the person's outings are short, infrequent, or for medical purposes mainly. And I personally would argue that a weekly grocery shopping trip in a scooter should not disqualify for someone because, you know, food is essential. Not everybody has somebody who can do their grocery shopping for them, and it's a relatively short and infrequent outing. Sometimes agencies neglect to consider a patient's visual deficits, cognitive status, pain levels, respiratory status, and endurance. These are all issues that can make leaving home very taxing and even unsafe for someone. And the fact that a beneficiary can drive does not by itself mean that they can't be homebound. We often see this, written down that, they're not homebound because they can still drive. A lot of people can still drive, but they can still satisfy each of the criteria in those two prongs I mentioned earlier. So overall, we should be looking at the larger picture of a person's condition and their experience. Next slide, please. Okay, so let's shift now to the skilled service requirement. For Medicare home health coverage to begin, the beneficiary has to need a skilled service. And that triggering skilled service can either be intermittent skilled nursing services or skilled physical therapy or speech language pathology services. Well, what about occupational therapy in the home? The rule here is that skilled occupational therapy cannot be used to initiate coverage, but if the person needs skilled occupational therapy along with another skilled service and that other skilled service ends at some point, then they can continue to qualify for coverage with occupational therapy. Next slide. Okay, so what is the standard for skilled services? in determining whether a particular service that the person needs is skilled, Medicare is considering the inherent complexity of the service and whether it can be performed safely and/or effectively only by or under the general supervision of qualified personnel. In order to be covered, the service must also be medically reasonable and necessary based on an individualized assessment of the patient's clinical condition to either treat the patient's illness or injury, or skilled nursing can also be needed to maintain the patient's current condition or prevent or slow further deterioration. Similarly, therapy services could be medically reasonable and necessary not only to restore someone's function that has been impaired by their illness or injury, but therapy can also be to maintain the patient's function, even if restoration is not possible. Next slide, please. Some of you may know that the Center for Medicare Advocacy represented a beneficiary and a group of national organizations in a lawsuit called Jimmo versus Sibelius. The settlement in that case reinforced and clarified that a patient's restoration potential is not the deciding factor for whether Medicare coverage is available. And that, even if full recovery is not possible, a patient may need skilled services to prevent further deterioration or preserve their current capabilities. So in short, the ability to improve is not required for a service to be considered skilled or reasonable and necessary for the person. Next slide, please. Okay, so let's talk a little about skilled nursing. The statute requires visiting nurse services to be intermittent or part-time. What does this mean? This means that nursing visits must be provided on a less than daily basis, but at least once during a 60-day episode. Now, there are exceptions to both of these requirements. So a skilled nursing service that is provided less often than every 60 days could still be covered if there is a predictable recurring need for the service. So an example is if a person needs a medication injected intramuscularly every 90 days, let's say, or if someone has a predictable recurring need for a nurse to perform a bowel disimpaction. They can't predict a pinpoint exactly when it will be needed, but they can predict that it will be needed at some point. Now, sometimes a beneficiary might require daily nursing visits at home to perform wound care, for example. Now, the home health benefit will cover daily visits for up to 21 days with extensions in exceptional circumstances. For this to work, the patient's physician has to affirm the patient's need for additional daily care, which is finite and predictable. There's an end, there will be a finite and predictable end to the daily care. Next slide, please. Okay, there is an exception in that Medicare will cover, without limitation, daily nursing visits to administer insulin injections to someone who cannot self-inject, and if there is no other person willing or able to administer their insulin. And this may be the case for someone who lacks the fine coordination, visual or mental ability to inject insulin. Next slide, please. Okay. The regulations define specific skilled nursing services that can be covered. A doctor may order nursing visits to observe and assess the patient. And this is a covered skilled service when there's a reasonable potential for change in the patient's condition, and a nurse's skill and judgment is needed to evaluate whether the patient is responding to the current treatment or if further intervention is necessary. The visiting nurse can also be ordered to provide patient education services, which is teaching or training to the patient, family, or caregivers on how to manage the treatment regimen. And this can be covered for a reasonable period of time, and reteaching or retraining may be appropriate in some cases. Nursing visits might also be medically reasonable and necessary to manage and evaluate the care plan of a patient who requires skilled oversight of unskilled services. This might come into play with a patient who is medically complex or fragile to the degree that there's a heightened risk of complication in delivering essential unskilled care to them. When ordering this type of nursing service, the physician must include a narrative explaining why the patient needs this type of skilled oversight. And finally, the law recognizes that certain types of nursing services are by nature skilled. And this includes intravenous or intramuscular injections, IV or enteral feeding, suprapubic catheter care, certain wound care, and also treatment of extensive decubiti. Next slide, please. Skilled therapy is covered if there's an expectation that the patient's condition will improve materially, or the person's unique clinical condition requires specialized skills, knowledge, and judgment of a qualified therapy professional to design or establish or perform a safe and effective maintenance program that's required in connection with the patient's specific illness or injury. So what's key here is that the goal can be maintenance, doesn't have to be restoration, it can be maintenance. And the benefit also covers maintenance therapy that's performed by a therapy assistant now. Next slide, please. So this slide contains an important policy statement. Medicare expressly states that in deciding whether someone needs skilled care, their overall medical condition should be considered without regard to whether their illness or injury is acute, chronic, terminal, or expected to extend over a long period of time. Moreover, the patient's diagnosis should never be the sole deciding factor in whether they need skilled services. And the policy also recognizes that skilled care could continue to be necessary for patients whose condition is stable. Next slide, please. Okay, let's move on to dependent services. As you recall, if someone receives at least one of the qualifying skilled services, then coverage is also available for dependent services they may need in relation to their illness or injury, such as home health aides, medical supplies, or medical social services. Now, the type or amount of skilled services somebody receives does not determine the amount of dependent services they can receive. So it's incorrect and improper for a home care agency to say something like, well, because the nurse is only visiting once a month to change your catheter, Medicare won't pay for aid services. It's also incorrect for them to say something like, oh, you're getting so many the physical therapy services right now, you're not entitled to any aid. Medicare won't pay for any aid in that case. That's false, and it just doesn't work that way. Next slide, please. So how much home health aid service can be covered under the law? Under statute and regulations, aid services combined with skilled nursing services can be covered up to 28 hours per week, but they must be provided less than 8 hours on any given day. Now, in certain situations, subject to review on a case-by-case basis, coverage may be available for up to 35 hours per week of combined nursing and aid services. So as you can see, quite a considerable amount of coverage is available under the law. Next slide, please. Okay, and this is the reality check. In reality, we rarely, if ever, hear about people who get anywhere close to that level of aid service from their home care agency, even though the law expressly could cover it. in practice, beneficiaries are often told by home care agencies that Medicare will only cover maybe between 1 to 3 hours per week of aid service, if that much, and only to provide assistance with bathing, which is not true. Agencies often say that they do not have the staff to provide many or sometimes any aid hours or visits to someone. And we also hear about agencies suggesting that families find a private pay alternative for the aid services the patient needs. Next slide, please. So let's see, the benefit covers home health aides to provide hands-on personal care. If someone only needs homemaker services, that would not be covered. However, services like light housekeeping, meal prep, or simple errands are covered if they are provided incident to the hands-on personal care that the aid is furnishing. Now, people are sometimes told that they cannot get aid services because aid services are not skilled. Instead, they're custodial care, which Medicare doesn't cover. Now, that is a false claim. The statute establishes home health aides as a covered service under the home health benefit. It's part of a plan of treatment for someone's illness or injury. Next slide, please. Okay, the regulations define hands-on personal care as much more than just assistance with bathing. Covered home health aid services can include assistance with dressing, grooming, hair and nail care, oral hygiene, changing of bed linens for an incontinent patient, assistance with feeding, elimination, routine catheter and colostomy care, foot, skin, ear care, help with bed mobility, transfers, ambulation, medication assistance, and simple dressing changes for wounds or skin issues. Next slide. So what about the impact of having caregivers at home? We are definitely seeing a trend in patients receiving less and less home care services being provided, particularly aid services. And this is especially so if the patient lives with a spouse or other family member. Sometimes, the agencies, when they take a patient on for service, they presume that if somebody's living with a patient, that person can just handle all of the hands-on personal care. And that's not always true. Maybe they've been filling in because there's been nobody else, but it's not ideal, and it might not be, it's just not, might not be sustainable. Now, under Medicare policy, a patient is entitled to have the costs of reasonable and necessary services reimbursed by Medicare without regard to whether there's someone available to furnish the services. But where someone is or will be providing services that adequately meets the patient's needs, it is not reasonable and necessary for the home health agency to furnish them. There is a presumption that there's no able or and willing person at home to provide the services unless the patient or family indicate otherwise, or the home health agency has firsthand knowledge to the contrary. So I think the key thing here is, it's important that home health agencies don't just assume. There's a presumption that there isn't anybody under the policy. There's a presumption that there isn't somebody able to provide those services. And, they can't just assume that just because somebody's living there, like a spouse or other family member, that, that's going to adequately meet the patient's needs. They need to sit down and have a conversation about what kind of care the patient needs and who, reasonably, and effectively can and reliably can be and safely can be providing those services. With that, I'll turn it over to Kathy.
Hi, good afternoon, everyone. Can I have the next slide, please? So I want to briefly talk about the obstacles to accessing Medicare covered home care. Wei Wei touched on a number of them, but I also want you to kind of have a basis or an understanding of where the problems are lying and what we're trying to address as an advocacy organization. Next slide, please. So law versus reality. Wei Wei did a fabulous job kind of laying out what is the law, what is the coverage available to people with home health, and what is the reality, something that I want to just touch on here. The important thing to know is that Medicare does not require home health agencies to provide services. So what ends up happening is when Medicare does provide those services and does offer coverage, I'm sorry, when the home health agency offers the coverage, then Medicare will pay for it. So the question is, what kinds of incentives are necessary in order for the home health agency to want to take your case on? So it's important to know that Medicare policies, payments, and practices don't implement the coverage law. That's what we're seeing. If they did, then everyone would be able to get all of the services that Medicare covers. What's happening is this is resulting in a narrowed provision of services that favor people who have shorter term and post-acute care needs. Someone who's had a hip replacement or knee replacement needs a limited period of time in order to achieve independence. Most of the patients that we hear from and that we work with are involved in what was known as the JIMO settlement, as Wei Wei described it to you, people with chronic and longer term conditions such as paralysis. And access to home health aid services has all but disappeared. Now, I don't want to paint too bleak of a picture. We know that there's an impact of the policies and practices of the Medicare payment system, quality measures that reward agencies for serving people with criteria such as improvement in their ability to be mobile or to independently bathe. Those types of criteria are important for people who can improve, but Medicare needs to do a better job creating criteria that measures quality for people who have longer term chronic conditions, who really need home health services to have a better quality of life and to maintain as much of their functioning or condition or pain-free life as possible, as much as possible. And then there are also audits that are conducted that create some obstacles because the auditors are looking specifically for people who have been on service for a long time. I can tell you that we know of patients that have had Medicare paying for and covering and paying for home health services for years and years at a time. As Wei Wei mentioned, there's no limit to the amount of services that people can get as long as they qualify. Next slide, please. So these access problems are something that we really are trying to address. And I don't want to spend a lot of time on our statistics, but I just want to give you a sense of what we know has been happening. So as a percentage of the total home health visits by both skilled individuals and home health aides, the aid services have declined in the last 20 years from about half of the total visits to 6% of the total visits. What's important to note about that statistic is there is absolutely no change in the coverage laws for Medicare. The changes have been very specifically tied to payments, quality ratings, and audits. And the other statistic that's really stunning is the amount of profit that home health agencies are making based on how they're picking and choosing patients to serve. And there are questions about whether or not the Medicare payments are appropriate. So it's important for all of us to recognize the services that should be provided and find a way to make sure that the coverage that people are entitled to through this program are equally distributed in such a way that everyone in the Medicare program can obtain the services that they need. Next slide, please. So again, I won't spend much time on this slide. This is again just to point out the information that we're following about the payment quality and auditing problems that are creating this this obstacle to getting care. Next slide, please. So I want to go through a case example very quickly of an individual who was having difficulty accessing home health care and how we were able to help him. This is Mr. So. He had ALS and he needed all types of services that were provided through the home health care. He got services in place, and after 6 weeks, the home health agency said, well, Medicare says we need to discharge you. The doctor did not agree to the discharge, but the care ended. And Mr. So declined rapidly over 60 days, having no home health services. They were helping him to stretch. They were helping him to do physical therapy, occupational therapy, and he had a home health aide that was coming in to help with his transfers and his showering and all of the other types of services that his wife, who was 300 pounds smaller than he was unable to provide for him. So all of the services were restarted by the home health agency after he declined. And then the home health agency said, well, we can only come in for 6 weeks. That's all Medicare is going to allow us to do. The agency refused to show the patient the plan of care. So the patient and the patient family had no idea what the agency was going to provide. And the physical therapy originally stated, well, there's no point in giving this person physical therapy. They're just going to decline. We're just going to, the sooner rather than later kind of a situation. The doctor ordered aides twice a day. He would have been entitled to up to 5 hours a day under Medicare, and the agency only came in and provided a bath every 2 weeks. So when questioned by the family, the agency said they had one home health aide for 500 cases, and they were receiving more than $16 million of Medicare revenue. But they did have a private pay department for aid services. So, let's go to the next slide, and I will tell you exactly how we approach this case with the family. As long as the patient qualifies, home health care can continue, right? We know that. There's no cap or limit on length of service. The discharge should not happen without the doctor's agreement under the Medicare conditions of participation. Those conditions of participation are the rules that allow agencies to become Medicare certified. They have to agree to those conditions of participation in the program. Within the conditions of participation, there's a patient bill of rights that requires that the patient be provided with a plan of care when they request it. So the agency was way out of line. Medicare covers physical therapy to help maintain or slow decline of function. Despite any physical therapy or any agency that says there's no point in this, that is not only is that, therapy malpractice, that's just wrong. And there's a lot of reasons why people need to have therapy. The home health agency has to provide all of the services as ordered or arrange for services through although the orders are sometimes changed after the agency assessment. So the way that it works is that the doctor or the provider orders the home health services. The order is taken by the home health agency, who then comes and assesses exactly the needs of the patient. Sometimes there can be rather a negotiation between the ordering doctor and the agency. They have to come to a meeting of the minds. That's why it's really important for the order to be the person who's doing the ordering to be strong about what's necessary for the patient. And the shifting of aid services to a private pay division is just, it's something that is unfortunately allowed right now, But we really are tracking this because we feel that it's at best unethical, but it's something that has become a big problem with agencies not providing enough staff in order to help people who need the services covered by Medicare. So, and in this particular case example, we were able to help the family to obtain more services for longer. And we worked with the family to make sure that this was possible. Again, there was no way that we could have demanded that the agency provide these services. We approached it in such a way where we said, look, this is, your mission is to help people. This person needs this assistance, and we're asking for you to provide it. The squeaky wheel gets the grease. So that's kind of the bottom line of that case example. Next slide, please. So now we'd like to be able to answer any questions and discussion. I will say that the slides that follow this one, which are practice tips, resources, please use those as you need them. There's a lot of information on our website that will help to provide step-by-step process of how to work with home health agencies, but we are happy to answer questions.
So thank you, Kathy and Wei Wei. Wonderful presentations up to now. I'm looking in the Q&A box and not seeing any open questions at the moment, but to your comment about, or to the last comment about advocacy being, patient's family, CMS, and so on. What if a patient has no family or immediate family to advocate for them? What should somebody do?
I can start, and then Kathy, you could. So sometimes in these cases, the patient's physician could be a really important advocate on their behalf. Sometimes the physician might have experience with the particular home care agency, or knows of one or two agencies that have been better at providing services to the physician's patients, and would be willing to really talk to the nursing director at the home care agency, and really explain the clinical reasons why they need the type and amount of services, and that this patient needs, and if it's a question of continuing those services, being able to justify to the agency why that continued care is necessary.
Okay, well, we're beginning to get some questions here. Daphne asks, what is the process for starting home health services, meaning, documentation and forms, that sort of thing, if somebody wants it?
Wei, do you want to start, and then I can?
Sure. So there can be different routes of getting home care services, and I think we mentioned sometimes people begin services after they get out of the hospital. That's one way. And what usually happens there is that there's a discharge summary from the hospital, and it's recommended that the patient is discharged from the hospital onto home care. And so that kind of starts it off, but the patient is going to have their community physician. They have to be followed by a physician in the community who actually certifies the home health plan of care, and is able to document that this patient is homebound and why they need skilled services at that point in time. Now, there are also people who start in home care just directly from the community, not having been hospitalized or being in a nursing facility. They feel, and their doctor feels, that they really do need some kind of skilled service at home to either, provide observation and assessment or education about their treatment regimen, or, one of the skilled services I had talked about. And then it still works the same way, where the treating physician is going to have to coordinate with the home care agency regarding which services the patient needs, and get all that documentation in place that the agency would need to be able to submit a claim to Medicare for those services.
And to that, I think I would add, we know that 2/3 of Medicare home health episodes are from the community, where people don't go through a hospital. So it's not unusual. It's actually the majority of the cases are what's referred to as community admissions. And oftentimes we say, check with your doctor if they have recommendations. Have they heard of home health agencies that are good, that they would recommend, that they've worked with in the past? The other opportunity, if there's no kind of direction there, is the Medicare.gov website, which is the official Medicare website, has a tool called Home Health Compare. And you can just search Home Health Compare on Medicare.gov, and it will bring up a zip code where you can put in your zip code, and it will tell you all of the Medicare certified home health agencies that serve your zip code. And then you can click on each one of them and find out more information about what kinds of services they offer, and what their ratings are, and that kind of information.
There is I'm sorry, wait. Did you want to add something to that?
Just one other thing, which is in having conversations with your physician, I think physicians might be more familiar with skilled care and might not think about the dependent services like home health aides that might be needed. So it's important to talk to the physician about that too, and make sure that that's included in the plan of care if that's something that the patient could really benefit from. Their health could benefit from that. Yeah.
Okay. I want to move on to some more questions. Somebody in the chat said that you mentioned help is available for less than 8 hours a day. Does that mean 7.5 or 8 fully? And is the patient's care providers, is the patient's care provider's condition or limitations taken into consideration when determining how much care will be provided?
Okay, I can start, and then Kathy, please jump in too. To answer your first question regarding the 8 hours per day rule, so that is just a limitation. The law states that Medicare will pay for up to 28 hours per week of combined nursing and aid, but that combined nursing and aid cannot be more than 8 hours, happening more than 8 hours per day on any given day of the week. So yes, 7.5 could be covered. Even 8 could be covered. It just can't be more than 8. And then overall, it can't be more than 28 per week, 28 hours combined per week. But in certain special circumstances, Medicare could cover up to 35 hours per week of combined aid and nursing services. It's very hard to get that kind of coverage from home care agencies. They're reluctant to provide that level, even though some patients might need it and it's coverable under the benefit. So, and then to answer your second question about whether the caregivers, capabilities are taken into account, my answer to that is it should be. They should definitely be taken into account. When the home care agency is evaluating the service, what kind of the amount and type of services this person needs, they should be looking at, you know, the caregiver's actual ability, whether they have their own limitations, as you said, and you know, they might have their own health issues too that could, you know, we don't want to be creating more problems by not providing any services, you know, so.
Okay, great. There's a couple of questions related to coordination between the VA and Medicare's home care benefits. One questioner has a brother who's part of the VA's home-based care program and wonders if they can get supplies through Medicare as well. And then there's just a general question about how does Medicare work with VA coverage?
I'll tackle that first question. The supplies, if you're getting home health care through Medicare, I'm going to address the Medicare first. I know that wasn't the exact question, but I can just say that Medicare has what's known as a consolidated billing arrangement, which means if you're getting any of those services that Wei described from a Medicare home health agency, Medicare can only pay the agency. And then the agency, if the agency, say the individual needs a piece of equipment for physical therapy that's not available, the home health agency may make arrangements for that to be brought into the home, or the person to go to a hospital, say a rehab facility, for that piece of equipment. Medicare will not make a separate payment. All of the payment goes through the home health agency, and then the home health agency has to make arrangements for all of the care to be determined. The same thing is about the supplies. So supplies that a home health agency would bring in, that full payment you have to show that you're getting all those other services through Medicare. I think it would be a really difficult thing to go through the home health benefit to get extra services to supplement the VA benefit. And the only thing that I can think of other than for that particular question, other than that, is if Medicare Part B might pay for something that's covered under Medicare Part B that's not part of this consolidated billing arrangement that the home health agency has to go through, because that's a much more complicated process. So I would see if those could be paid for under another part of Medicare rather than the home health. With regard to coordination of benefits, Wei may know more about this than I do, but I am not aware that there is a specific coordination of benefits. There may be something additional that the VA offers and that Medicare offers, but I don't think that they coordinate.
Right. I don't think they coordinate. And what we do know is that the VA is going to probably want to see a denial by Medicare. They want to see how much Medicare is covering before the VA benefits will fill in what, you know, Medicare is not covering. So typically, you know, they might want to, VA might want to see your Medicare summary notice that you get on a quarterly basis stating what's covered, what's not, and submit that to the VA. And that way they know what Medicare has decided not to cover and not to cover.
Thank you. Got a number of other questions, some of which seem to be case specific, and I know you all offered to address individual case questions after the webinar, so we will pass those on to you. Quick question, can a family member be reimbursed for caring for the patient if there's no home health aid available?
No, unfortunately not. This is part of that consolidated billing arrangement that I talked about. The whole amount of money that's available, and Medicare pays on a kind of a capitated bundled payment, if you will, to the home health agency for all of the services. So there are very specified requirements in Medicare of how a home health aide is trained and the amount of training hours that they go through. And trust me when I know that family members are so much more trained and understanding of what needs to be done than the aides are. But at least right now, there's no mechanism in Medicare to reimburse for family or friends, or even, you know, if you pick up aides from companions and homemakers or some other non-Medicare certified organization, Medicare will not cover. They will only cover the aides that are employees of the home health agency, or that the home health agency has made arrangements with, which makes then the home health agency responsible in case anything happens.
Thank you. I think we've got just about time for maybe one more question. One person asks about Medicare Advantage plans, and they receive a capitated rate and don't provide the home care benefit due to their network home care agency's inability to have sufficient aides available to provide care. Are Medicare Advantage plans liable for failure to provide a covered benefit?
So to that, I would say that Medicare Advantage plans are required by law to provide the same amount of type of services that are available through Medicare Parts A and B. So everything that Wei went through with you about coverage is exactly true for Medicare Advantage plans. Obviously, Medicare Advantage plans have narrower networks. They don't have as many providers that an individual can choose from as there is in traditional Medicare. But I would put some pressure on the Medicare Advantage plan to say you are required to provide all Medicare Part A and B covered services. They are covered. Home health care is covered under both Medicare Parts A and B. And therefore they should be meeting those standards and those rules. And oftentimes what we advise families to do is take our materials, take this webinar information, show them where, you know, the law that this applies to, and push against them. That's the squeaky wheel thing again, that these services are needed, they're necessary, and they're covered by law under Medicare.
Okay, well, we're running up against our hour time frame and may not have gotten to all our questions. Like I said, we do have some questioners who left their names, and we'll be able to get them to you for follow-up individually. If people do have continued questions, how can they reach out to the Center for Medicare Advocacy?
Well, most of all, I would say to people, please look at our website. We have a lot of resources. We have a lot of information. We have a fairly small staff. We're small but mighty. And as I said before, it's really important for us to communicate that we cannot force the home health agencies to take people. Oftentimes we just say, please look at our materials, look at the information that we are trying to provide to as many people across the country as possible. If you have specific information, we do have a specific question, I'm sorry, that you want to ask. We have a new email. It's homehealth@medicareadvocacy.org. Same thing that you're seeing on the screen there, but just homehealth@medicareadvocacy.org. We can't promise that we will be able to provide extensive consultation. We will try to respond as best as we can.
Thank you. I want to thank Kathleen and Weiwei for a very informative presentation. We're most grateful to you all for sharing your knowledge with us and for the work of the Center for Medicare Advocacy. And like we said, the slides will be available to our registrants once this is posted on the website. And we will get the other questions answered individually afterwards. And again, thank you everyone for joining us today, and have a good Wednesday. Take care.
Thank you.